Welcome back, everyone. Thank you for staying with us throughout this second day of our conference. We're going to have an interesting session coming up. We are starting our session with a presentation from our patient registry coordinator, Sophia. And Sophia is lovely, and we are looking forward to hearing from her. So Sophia, go ahead and take it away.
Thank you, Heidi. Hi, everyone. It's such a pleasure to be here. My name is Sofia Balog, and I'm the patient registry coordinator for the CreatineInfo registry and natural history study for Association for Creatine Deficiencies. Oops. There. Today, I'm excited to share with you an update of our registry, the one we launched this year, back in March this year. This registry is completely owned by ACD and is hosted by the National Organization for Rare Disorders. So when I joined ACD 1 year ago, the ACD board had some really in mind, really thoughtful priorities about this registry. They had been thinking about this tool for so long. So when we had this meeting, they already knew what they wanted. They wanted an engaged community. They want this to be the first source for researchers looking for information for creatine deficiencies. And they want this to be easy for families, user-friendly. They want to be patient-centered. They had so many ideas, and it was great to get on board this project and work to make this happen. So after 6 months, we created a beautiful group of people who helped making this happen, the Registry Advisory Board. The Registry Advisory Board is confirmed by the Medical and Scientific Advisory Board for the registry, a Family Advisory Board. Some members of the board are in this conference. So thank you so much for all your hard work with the registry, for testing, for your input. It has been such a journey, and having this journey with you has been so wonderful. Thank you. And the ACD board, who oversees the development of the registry and pursues all collaboration that can lead to treatments. So we are a strong team, we are a big team. And I would like to introduce the Registry Medical and Scientific Advisory Board. Thank you, Dr. Nicola Longo, Dr. Stockler, Andrew, thank you so much. Dr. Porter, Beth Porter, who did patient outcomes and core outcomes talk yesterday. Thank you, Audrey Thrum and Fadi Hannah Sweeney, for your inputs and your help with this registry. So we launched the registry back in March 15 this year. This registry is for CTD, for GAMT, and for Agat, and it's meant for all patients around the world. Patients and caregivers can join the registry, and this registry is patient-reported. So meaning that only patients or caregivers can contribute data to this registry. The platform hosted by Nord is really easy to use. We received really good feedback from families about this platform, about how to find information. We are able to communicate with the families within the platform. So we are really happy about how we are building this registry. So when we launched the registry, we decided to go with short and initial surveys. Not a long list of surveys from the beginning, but just to start working and engaging with community. 5 short surveys to start. And this is a little taste of the data we are getting on surveys right now. We are getting some information, social demographic information, some information on diagnosis, which are those diagnoses that patients received prior a CTD or a GAMT or Agat diagnosis, which are those diagnoses that came after. So here we can see that before, there were many different diagnoses, and when they received because of genetic testing or other testing, and the CTD diagnosis, many of the patients was the last diagnosis that they received. Also, we are working with different strategic partners. We are working with Clinton from NIH. We are working with Nord. They're helping a lot with this registry. CCI, giving a space of exchanging experiences with other groups, and Rare Genomes projects where we are getting on board a project to find prevalence for CCDS. So yesterday you heard from Beth Porter about the importance of the patient voice when thinking about core outcome sets. And we are working with Beth and with Dr. Stockler on making this for the registry. We want to hear about the families, what is the most important to CCDS families. So yesterday we launched our patient meaningful outcome survey. We are already seeing some responses. So thank you families for participating. Please after the conference, if you can go to the registry, take the survey. This will give us so valuable information we can share later, and we can communicate with the researchers what is the most important to you. So thank you, Beth, thank you, Dr. Stockler, and thank you all the Registry Advisory Board for putting this together. Also with Dr. Stockler, we are about to share on our website Creatine decoded educational essay talking about the importance of patient registries and patient-led initiatives, and how this can accelerate treatments. Thank you, Sylvia, for your kindness and for sharing this great interview that I'm excited to share with the CCDS community. What is coming next? We are working with different researchers on different surveys, seizure, cardiovascular health, CCDS disease management, medical reports, medication, and we are open. We want to hear first from community, where is this registry going for them? What is the most valuable for them? But we also want to hear from you, researchers. We want to hear from you. If you need information, if you need data for your studies, please reach out. We will be happy to work in partnership. This registry is completely managed by ACD and is intended to support all research initiatives that work towards treatments for CCDS. So please feel free to reach out to me, to Heidi, to Laura, Sangeeta. We'll be really happy to hear from you. To finish, the message that I want to leave today is we are a strong community and we are ready to move research forward and make our voices heard. So we are ready to work with you as partners in research. We are ready to start new projects. We are getting stronger and stronger every day. Thank you, ACD, for this opportunity to lead this amazing project.
Thank you so much, Sophia. Thank you for all of your hard work to develop such a powerful tool for our community. Hopefully you can see my screen and hear me. All right, today I would like to talk about the vision of ACD, and our vision is that, of course, we've talked about this throughout the conference so far, that there will be a treatment for all creatine deficiencies, including improved treatments for Agat and Ctd deficiency. But also part of our vision is that one day families will not face the long and winding road that is usually our story in getting a diagnosis for our child. We shared a poll before the break asking families what method was used in obtaining their child's diagnosis. And I'm sharing those results with you right now. From the folks that are on the call today, we had one report that their child was identified with a creatine deficiency, likely through MRS, and all others through genetic testing results. This reflects that these families saw a need, that their child was declining. They were in a panicked state that we can all understand, and looking for answers. And we feel that this is not acceptable, especially for the diseases that have treatment, but in the long run, for all creatine deficiencies, we want to see this change. So I want to introduce myself first. My name is Heidi Wallace. I'm the president of the Association for Creatine Deficiencies. I also work for the Utah Public Health Lab in the newborn screening program. And why I ended up in both of those roles is my most important role, which is the mom to 4 children, 2 of which, Samantha and Louie, both have GAMT. And Samantha was diagnosed at 5.5. Like so many other children with creatine deficiencies, after many, many years of treatments and concerns and missing milestones. And thankfully for Samantha, her younger brother Louie was diagnosed shortly after birth. And so our family especially understands the importance of early diagnosis. I want to go back quickly and give you a history of GAMT, just a quick look of where we've been over the last 27 years. In 1994, GAMT was discovered. Then in 97, diagnostic tools were established to be able to screen for GAMT. In 2004, Australia decided to add GAMT to their newborn screening. This was of their own volition. They felt that it was an easy add, which it is, and why not look for it while they're screening for all of these other disorders. In 2009, Austria started a pilot program to see if it were feasible to screen their population for GAMT. In 2014, British Columbia also started a pilot. And then in 2015, Utah began to screen using a derivatized method the entire population ongoing. So in 2016, a year later, Dr. Longo led the nomination for GAMT to be added to what is called the RUSP, or Recommended Uniform Screening Panel. This is a panel that is maintained by the US federal government that recommends to each state, this is a list of disorders we think that you should be screening for. And based on their criteria of a disorder needs to be serious if it's not identified, very difficult to identify until after symptoms have started, it needs to have a treatment, and it needs to be a screenable disorder. We felt that this was, the perfect candidate. And there was a heated debate, but unfortunately at that time in 2016, the committee that reviews disorders decided not to move GAMT forward for further review because they wanted to find one baby prospectively using newborn screening, just for that extra bit of proof to show that the screening works. So we have been waiting. And in 2017, British Columbia changed from a pilot screening of GAMT to routine screening, and they have been screening ever since. And then in 2018, New York joined Utah in screening their entire population. In May 2021, the Ontario Newborn Screening Review Committee decided to advance GAMT forward for ministry approval. And then in August 2021, we renominated GAMT to be considered in the US by the RUSP committee once again. So what happened? Well, we've had 2 small miracles in the last 12 months. In December 2020, pictured here, little baby Woody was born in Utah, and he was identified as having GAMT. A little backstory on Woodward is that family is not there. They were not living in Utah, but because of COVID at the time, they decided to come to Utah to be near family. And even then, they weren't sure that they would have their child in Utah, but in the end, they decided to stay. And had they not stayed in Utah, we know the course that likely would have been followed to finally get a diagnosis. And then just a couple months later, in February of this year, New York also identified a baby with GAMT. And just for a little background, Utah had screened 273,000 babies prior to finding baby Woody, and New York had screened 537,000. The most recent estimate that I have heard for GAMT is that it occurs 1 in 250,000 births, but that of course will become more clear after there is more screening in more labs. So following the birth of these 2 babies, New York and Utah decided to collaborate and write a paper. Myself, Dr. Longo, Dr. Pasquali contributed to the paper, and it contains some really great information on the history of the screening in both of those states, the methodology used, and the application of screening for GAMT in other states. Some of the information is highlighted here in this table. Of particular note is the method. Initially, Utah had been screening through ARUP Laboratories using a derivatized method, and then they had switched to underivatized in 2019, which is the method that was used to identify baby Woody. And then New York was using the derivatized method, and they had, like I said, screened over 500,000 babies. One thing to note that is important to all of us, but especially to review committees, is what is your rate of false positives, and how much burden does that put on the lab to screen for your disorder if you're constantly having to rescreen babies that don't actually have the disorder. And you'll see a slightly high number here with New York. This elevation was addressed by adjustments to their methodology. And after that adjustment, they have had very low false positives like the other countries and states have seen. So the conclusions from this paper I will share with you. Newborn screening allows for the prospective identification of GAMT deficiency utilizing elevated guaiac concentration as a marker. First-tier screening may be incorporated into existing methods for amino acids and isocarnitines without the need for any new equipment or staff. Newborn screening performed by either derivatized or non-derivatized methods and coupled with second-tier testing has a very low false positive rate and can prospectively identify affected children. One thing to note when you are reading this paper is our use of the term guaiac. In the newborn screening world, Pompe disease uses this term GAA, and so we've gone ahead and acknowledged that, and to reduce confusion, we are using the term guaiac quite frequently, so we wanted to bring that up. So the vote, back to our renomination. GAMT was reviewed by a subcommittee. They came to the entire group to give their suggestions on the evidence they had reviewed, and there was a vote, and it was a unanimous yes. So what are our next steps here in the US? This committee has less than 9 months to review the disorder and make a recommendation. That puts us at May 12th of 2022. During this time, the review committee will meet with a technical expert panel, and we're pleased to share that Dr. Longo, Dr. Pasquali, Dr. Schulze, and myself were invited to participate in this panel so that there will be constant feedback and no misunderstandings on the disorder. And hopefully after that 9 months, the evidence review committee would go to the Secretary of Health and Human Services and make their recommendation to move GAMT forward to be included on the RESP, and then he would agree with that. And then at that point, we'll be up to a state-by-state approach to adding GAMT. So our plan with the state-by-state advocacy is to first pick the best candidates. There are some caveats here on who would be best to start screening right away. We have been in communications with PerkinElmer, and they are working on adding GAMT to their non-derivatized kit initially. And so states using that kit would be very good candidates. They are hoping that there will be a state that will at least run a pilot and give them some data back. So if there are people in the audience today who have recommendations and connections, please, we welcome them, reach out. The other states that would be good candidates are states that use lab developed testing and not kits. So they are more free to make these changes as they see fit. And then following that, we want to work with our international ambassadors to be advocating beyond the US in all the newborn screening programs. While it does help tremendously to get this on the US's panels and to get that data and exposure, we don't want to lag behind in other areas. So some additional implications that have come up. Elevated guac may be a secondary marker of Arginase deficiency. There is observed in the paper that I shared earlier a positive relationship between elevated arginine and elevated guac in patients that actually did not end up having GAMP. So looking at the level of arginine could be a good indicator in deciding what your thoughts are on a borderline guac level. And as I mentioned before, PerkinElmer is working towards adding GAMP to their non-derivatized kit. So what about Agat and Ctd? So with Agat deficiency, as everyone knows, Guanedino acetate is very low. And what's been seen so far is that it is likely very difficult to differentiate a Guanedino acetate from an Agat patient from the general population because of the lower level of detection of the instruments used to do this testing. But the hope is that perhaps more sensitive instruments as technology improves, this may help in possibly screening for Agat deficiency. And then for CTD newborn screening, one of the criteria that I mentioned is that there needs to be a treatment for a disorder. And so there may be some perspectives that this isn't something that we need to pursue right now. There's no treatment for CTD, so states won't agree to add something that they can't at the same time help the families treat. But ACD would argue that we need research now. If we wait for a treatment, this will likely cause delays on adding CTD to panels. We've seen already the long road from when the diagnostic tools were developed for GAMP until we are now just hoping to start getting GAMP on more panels. And so CTD newborn screening research is very much needed. And I would even put out there that if you have CTD mice or rats and are willing to do a newborn screening blood spot collection, please contact us and let us know. So one final approach that the ACD takes to get an earlier diagnosis for our families with a creatine deficiency, which we have been pursuing since our start, is to educate. And one of the tools that we're excited to be launching very soon is a relaunch of the Screen Creatine website. You may be familiar with Screen Creatine from its earlier launch. We've taken over the website and we're rebranding it. And we're going to use this site a little differently than our CreatineInfo.org, which is mainly focused on general information, connecting parents. The Screen Creatine site will be a tool to identify clinicians globally. So healthcare providers who have a recent diagnosis and maybe have no familiarity with creatine deficiencies will have a tool to locate someone who has agreed with ACD to be listed as an expert and to be contacted. And also testing laboratories. Sometimes there's difficulties in finding labs that will screen for all of the different analytes that are needed to properly screen for a creatine deficiency. And so we will host some newborn screening resources there as well to help with methodologies in newborn screening and distribution of information. This fall, when we complete the relaunch, we will be mailing out information to physicians in the US, and we will also be working with our international ambassadors to share the same information outside of the US to target specific metabolic folks and neurologists that are the most likely to see these patients, to make sure that they are connecting them with patient registry, and also just to keep creatine screening at the forefront of their minds. So I want to wrap up with saying that I think probably everyone recognized little contributions throughout, like newborn screening in British Columbia and Ontario and here in Utah. And it's because of a fantastic community of researchers that have committed so much time and energy into our efforts that we have made so much progress, and we are very grateful and hopeful for the future of newborn screening. And with that, we will now switch to our plenary speaker, Dr. Marzia Pasquale. Dr. Pasquali is a professor of pathology. She's also the program director of the ACGME accredited fellowship program in clinical biochemical genetics at the University of Utah School of Medicine. And she is the section chief and medical director of biochemical genetics at ARUP Laboratories. So Dr. Pasquale, if you are on the line, you can go ahead and start sharing your screen.
Can you see my screen?
Yes.
Okay. Thank you for inviting me to share my experience with cerebral creatine deficiency syndromes. It's very encouraging to see all the work that has been done for therapy. But bottom line, we need to identify the patients first. We know that early treatment is a key for an effective outcome, for a good outcome. So let me quickly go through the Cerebrocrating deficiency syndromes, even though after these 2 days, I think we know, everybody knows what they are, but these are disorders caused by defects in creatine synthesis or transport. They are characterized by intellectual disability, autistic-like behaviors, seizures, speech and cognitive delays. They can also present as moderate intellectual disability, attention deficit disorder, or, okay, should not have gone ahead. So there are typically, initially these disorders were identified because of the lack of a creatine peak in the, when MR spectroscopy of the brain was performed. There are, however, biochemical tests that can be used to diagnose creatine deficiency syndrome. And as we have heard, newborn screening definitely is effective. Can we, I'm not sure why this is proceeding by itself. Yeah, let's go back. Okay. Let's look at the function of creatine. Creatine serves as an energy shuttle between the mitochondrial sites where ATP is produced and the cytosolic sites where ATP is utilized. And again, creatine is phosphorylated to phosphocreatine by mitochondrial creatine kinase. And phosphocreatine transfer the phosphate group to an ADP molecule through a creatine kinase in the cytosol and forming ATP. Now, how is creatine? How do we get creatine? Creatine, there are two sources of creatine. One is from the diet and one is through a biosynthetic pathway. The biosynthetic pathway starts with arginine and glycine, and the enzyme arginine glycine amidinotransferase or Agat, which convert these two substrates into ornithine and guanidino acetate. This reaction, this is the first step in the biosynthetic pathway of creatine. Second step is the conversion of guanidino acetate to creatine. This occurs through the enzyme guanidino acetate methyltransferase and the use of S-adenosyl methionine as a methyl donor. Creatine then needs to be taken up by the brain, the muscle, in order to function, to perform its function. And this is done through the action of a creatine transporter. Creatine is then, and phosphocreatine are then converted into creatinine and excreted in the urine. So a block in an impaired function of one of the two enzymes involved in the biosynthesis of creatine will lead to a reduced concentration, reduced synthesis of creatine. In the case of Agate deficiency, we also have an accumulation of the substrate guanidino acetate. When you have an impaired function of the creatine transporter, the synthesis is not impaired. So guanidino acetate and creatine levels are going to be normal. However, because the creatine transporter is the one that's used by the kidney to reabsorb creatine, if it's not working, creatine will be lost in the urine. And so the concentration of creatine in the urine is going to be higher. This table shows the pattern of metabolites that we see when we use a biochemical test for the diagnosis of this syndrome. So in Agate deficiency, and again, Agate is the enzyme involved in the first step of the biosynthesis of creatine, we will have low creatine and low guanidino acetate in plasma. In Agate deficiency, we will see a low creatine and a high guanidino acetate in plasma. In creatine transporter deficiency, the concentration of creatine and guanidino acetate in plasma are going to be normal, but the urine creatine, once it's normalized for creatinine, is going to be very high. The diagnosis is then confirmed usually by molecular testing. Enzyme assays and transporter assays can be helpful, but are not readily available, at least in a clinical setting. So let's look at each condition one by one, and let's start with Agate deficiency. Again, to reiterate, blocking arginine glycine transferase will result in reduced concentration of the product of the reaction. The immediate product is guanidino acetate, and the downstream product is creatine. So this condition, again, is inherited as an autosomal recessive disorder. The incidence is unknown, is probably the rarest of the three conditions. Very few patients have been reported to date. How low are these concentrations of guanidino acetate and even creatine? So the data that I'm going to present today are a summary of clinical data that we have accumulated in the last few years of testing for creatine deficiency syndrome. The patients that we have seen with Agate deficiency, and again, the number is very small, had very low guanidino acetate concentration. They were either 0 or very close to 0. And this slide shows in a black circle the concentration in unaffected controls. The pink circle represent a patient with Agate deficiency. You can see that if you look at the plasma, for both guanidino acetate and creatine, the concentration is markedly reduced, and there is a pretty good separation between the unaffected controls and the patient. When we look at the urine, we start seeing a little bit more overlap with the unaffected control. And if we expand the region of the low concentration, you can see that the urine as a specimen type is not as specific as the plasma in identifying this patient. And again, we have overlap with the potential for false positive results, identifying the false positive result. So a take-home message for Agate deficiency, plasma is the most informative specimen type for diagnostic purposes. Moving to the second step in the biosynthetic pathway, which is the one catalyzed by guanidino acetate methyltransferase. A block in this enzyme will result in accumulation of the substrate guanidino acetate and a reduction of the product, which is creatine. Agate deficiency is inherited as an autosomal recessive disorder, and we have that both the lack of creatine and the accumulation of guanidino acetate affect the brain. The incidence, estimated incidence after the latest identification through newborn screening is probably around 1 in 250, 275,000. And again, what are the values that we are seeing in patient identified with Agate deficiency at diagnosis? Here I've shown you a range, and again, compared to the normal, to the reference range, there is a pretty good separation between the patient and the unaffected control. And this graph showed this point. I think it's very clear that the guanidino acetate concentration in plasma is markedly elevated compared to unaffected control. In this slide, the blue circle represents patient with Agate deficiency, and the values are the values at diagnosis. And again, even for the creatine concentration at diagnosis in all of this patient is very low. The same thing that we observed with Agate deficiency, urine is not a specific specimen type for the diagnosis of Agate deficiency. But in this case, instead of having the risk of false positive, we will have false negative results. So you can see here that there are a few patients with a value for in the urine of guanidino acetate that's overlapping with the normal population. And this is not an artifact of age groups, of grouping, having bins by age group. You can see that this is, even when you're using a continuous model, they are still overlapping, and the same is for creatine. In the next slide, I wanted to show you, so we have the same data, but I have added values represented by the red circle from a patient with Agate deficiency on the treatment. And on average, we can see that the treatment lowers the concentration of guanidino acetate in plasma, except for a few exceptions. The creatine concentration is much higher than the than the control. And again, one more time, when we are looking at the urine guanidino acetate, there is overlap for many patients with the normal population, and the same for creatine. So again, even for Agate deficiency, plasma is the most informative specimen type for diagnostic purposes. The third condition is creatine transporter deficiency. And as I said before, when we have creatine transporter deficiency, the synthesis of creatine is not affected. It's only that the uptake of creatine by the tissue and the organ that need the creatine that's impaired. So this condition is an extra-linked condition. And again, the incidence, I don't think we have some good figure for the incidence yet. It might be more frequent than Agate deficiency. This looking at our data, again, this slide shows you a diagnosis. Unfortunately, I only have one patient with values a diagnosis, but you can see that the plasma, creatine, and guanidino acetate were normal, or in the case of creatine, we see even a little bit above the normal range for age. But the creatine-creatinine ratio, again, creatine normalized for creatinine was high. And I'm going to show you in the graph, because that ratio depends on age. So I couldn't put all the reference ranges. Again, in this graph, the black circle are controls, the green circle are creatine deficiency, creatine transporter deficiency patients after they have been diagnosed, so on therapy. And the blue circle represents one patient identified in the last year with creatine transporter deficiency. Again, guanidino acetate and creatine in plasma are within the normal range. Their creatine is high, of course, in patients on treatment. Guanidino acetate in urine completely overlaps with the unaffected control, as expected. But when we look at the creatine in urine normalized for creatinine, there is, again, very clear separation between the patients with creatine transporter deficiency and the unaffected control. So in this case, urine is the most informative specimen type for diagnostic purposes. So having said this, when diagnostic workup is done on a patient suspected of a creatine deficiency syndrome, you need to look at both, because you don't know which one condition is going to be. So you need to look at both the plasma and urine, but keeping in mind that for Agate and Agate deficiency, a urine guanidino acetate, especially for Agate deficiency, a urine guanidino acetate in the normal range does not exclude the condition. You really need to focus on the plasma results. And for the creatine transporter deficiency, of course, you need to focus on the urine result. Now, I want to talk about newborn screening. And again, definition of newborn screening is a public health activity aimed at the early identification of conditions for which timely intervention can lead to the elimination or reduction of mortality, morbidity, and disability associated with this condition. So when you read this definition, you know that this applies to cerebral creatine deficiency, at least to some of them. And I want to talk specifically about the story of a newborn screening for GAM deficiency. This started with a family that had 2 children, and they saw in firsthand the impact of early treatment on the outcome. Then a physician and the screening joined the family, and the physician was determined to allow all babies with all the patients with GAM deficiency to be identified early, so to improve their quality of life and their outcome. And then a laboratory got involved, and so happens to be my laboratory, and my laboratory always has always operated under the motto, let's give the patient the best chance that they can get. So we joined the forces, and we demonstrated that newborn screening for GAM deficiency was feasible. And we were able to integrate the analysis of Guanedino acetate and creatine in our routine newborn screening method. And we were able to detect these 2 analytes simultaneously while doing the analysis of amino acid, carnitine, and succinylacetone. No additional sample was needed. And the cost of the screening, the additional cost of the screening is really very, very low. It's just the cost of the reagent. We used as a primary marker Guanedino acetate, and as a secondary marker, the ratio Guanedino acetate creatine. Why do we need a secondary marker, a ratio? Because this increases the specificity. These are data from our pilot study that we did. We analyzed 10,000 de-identified blood spots, in addition to blood spots that are from patients confirmed to have GAM deficiency. The red circle here are from the results from the patient with GAM deficiency, and the black circle again are the control. The vertical dashed line represent the cutoff for Guanedino acetate. As you can see, if we apply only the cutoff for Guanedino acetate, we see several samples that will have an increased value, a value above the cutoff that was set. By using a ratio Guanedino acetate creatine, which is represented here by the horizontal dashed line, we are increasing the specificity of the screening and reducing the false positive result. In addition to use this the ratio Guanedino acetate and creatine, we also used a second-year test. We introduced a second-year test. So all samples with an elevated Guanedino acetate and ratio Guanedino acetate creatine were subject to second-year testing by liquid chromatography tandem mass spectrometry. And this was to get rid of the possible interferences that were that had the same signal as Guanedino acetate, and only those with an abnormal second-year test were proceeding to confirmatory testing. Now, when we did our pilot study, none of only the sample from patient with GAM deficiency had an abnormal second-year test. So we decided, thanks to the Utah Department of Health, that was fully on board with implementing this screening. We went live and started the statewide screening for GAM deficiency. once we started screening the entire population, we realized that we had there were some patients, some babies with an elevated guanidino acetate on the second-year test. But most of these baby were in the neonatal intensive care unit. And when we looked at these babies, we noticed that there was a positive correlation between the level of guanidino acetate and the level of arginine. And of course, this is not surprising since arginine is a precursor of guanidino acetate. This shows you what we have seen. Again, when we looked at the ratio, we thought that the ratio arginine guanidino acetate could be a potential an additional marker to reduce false positives. There were not that many, but to reduce false positive even further. As you can see here, the open circle represent patients with Agate Deficiency, and the black circle represent unaffected individuals. So this was used also to reduce the false positive rate for Agate Deficiency. Now, at this point, so this table shows the summary of the results of the screening up until February. And as Heidi mentioned before, Utah, we are no longer doing the newborn screening for the state of Utah. The Department of Health is performing the newborn screening, and they have switched to a non-derivatized method. At the same time, other states have implemented statewide screening, like New York State. And these are the results, which are very important to me, because this result showed that no matter what type of screening you are doing, whether you are using a derivatized or underivatized method, no matter what type of algorithm you are using, when we did the screening, it was very easy for us to do a second-year test immediately. As soon as we saw an elevated guanidino acetate. We didn't repeat any sample, but we went straight to the second-year test. But other laboratories which do not have in-house the ability to do the second-year test, they can follow a different algorithm. So New York uses also a DNA reflex test. So no matter how you do the screening, and no matter how what type of algorithm you use, you can detect this condition. And the false positive rate is very, very, very low. Even if we calculate the positive rate based on 23 positive, screen positive, the false positive rate will be 0.004% perhaps. So this screening can be implemented by all laboratories, and again with the minimum impact on their cost. So what have we learned? So far? We have learned that even though this presentation has a mind of its own. Guanedino acetate can be within the normal range in urine of patients with GAN deficiency, even at diagnosis. So measurement of guanedino acetate in urine to diagnose the GAN deficiency can lead to false negative results. Therefore, it's not the specimen type of choice for diagnostic confirmation of GAN deficiency, especially in newborns. Plasma should be used. Low guanidino acetate in urine is now specific for Agate deficiency, and this can lead to false positive results. So again, for diagnostic confirmation of Agate deficiency, plasma should be used. And creatine in plasma of patients with creatine transporter deficiency can be normal or even mildly elevated. Urine is the specimen of choice for the creatine transporter deficiency. We know now that newborn screening is feasible and effective for GAN deficiency. And I think that soon we will be able also to implement newborn screening for Agate deficiency and perhaps even for creatine transporter deficiency. And the specificity of the newborn screening for GAN deficiency can be increased by using ratios such as guanidino acetate over creatine and guanidino acetate over arginine. And I would like to acknowledge everybody who has been instrumental in collecting all the data and performing analysis and bringing the newborn screening where it is. At ARUP, our biochemical genetics newborn screening lab, our research and development lab, and the information technology department, the Department of Health, the newborn screening and follow-up program, University of Utah, the Division of Medical Genetics and the Metabolic Clinic, and last but not least, the patients and families, the Association of Creatine Deficiency, and again, all the patients and families, because they are really the true inspiration of all the work that I do. Thank you.
Thank you so much, Marzia. That was a wonderful presentation. And we have quite a few questions that have come in. So we will go to our Q&A. Dr. Schulze, would you like to start it?
Sure. I guess we start with the very first questions. And there are a couple related to the registry for you, Sophia. So how many participants are already in the registry? And how can clinicians post survey on the registry?
Thank you, Dr. Schulze. So today, 6 months after we launched the registry, there are 115 participants in the registry. This registry to be from all families. We want everyone to join, but it was a great start. And the other question was, how can clinicians
how the clinicians can get survey results?
Just reach out to Heidi, to Laura, to me, Sangeeta. So any clinician or researcher who would like to help in that path will be more than welcome.
Yeah, the survey is set up in a longitudinal manner. So we do plan on continuing to release new surveys. Our surveys are meant to be very short so that when families get on to complete a survey, they don't feel overwhelmed and never want to come back. So certainly we have, as Sophia pointed out, been working with many different people to make these surveys as quality and useful as possible, but I'm sure there are many components to be added, and so I think if a clinician identifies a need, they can reach out and we can start that process of developing a new survey to cover what we have not covered yet.
Good. So let's switch to newborn screening. And Heidi, if there's any of the questions that you cannot answer, I may be able to help out because my newborn screening experience goes back to 1992, so 2 years before I started to work on creatine. And so, so Heidi, okay. I think one very important question: how can parents advocate for newborn screening in their state? And I guess you could also say in their country. So, like in Europe, for example.
The quickest, easiest answer is to be a squeaky wheel, to be loud, to be finding out who is in charge of your newborn screening where you live, and do they have regular meetings. Even outside of the US, I think there's a lot of similarities in how newborn screening disorders are added to panels. While some countries have very, very, very small panels, I still think it's worthwhile to be telling your story, asking when the meetings happen, if you are allowed to be present at the meeting, if you're allowed to testify, and connecting with rare disease groups in your state or country, and finding out if there's platforms there as well.
Good. Then the next, do you know whether there is an international exchange between the RASP group in the US and corresponding committees in other countries?
I am not aware of another country that says we follow the RASP. My understanding from other countries is that it is much easier to add a disorder in their country if it has first been screened for and added to the RASP, so that there's more information, there's more pressure to say, well, we need to keep up. So that may be one, maybe you are aware of some kind of precedence, Andreas.
Mm-hmm. No, I think it's absolutely right. The committees in other countries have different processes, but there is no formal process that committees would interact with each other. It's, yeah. Heidi, if newborn screening is not available in my state, what can I do to get my child tested?
So if you were having a baby in another state and you wanted to rule out that they had GAMP deficiency, call me and I'll tell you how to buy a Utah kit and mail it to you. And this, I'm not the best to answer this question. I feel like it would be very difficult to go to a provider and say, I want this screen, unless you have a family history. I think that would be hard. There are some states that have supplemental newborn screening offerings that you can pay additional money for, and GAMT is not on those. Other disorders that are looking to be advanced like GAMT are, I think GAMT has kind of skipped that and hopefully will just be on the routine screening. So that would be a hard one unless you had a good reason.
Mm-hmm. Good. So I would propose we go to talk about Marzia's talk. There are a lot of questions too, and we can go back to a couple of more newborn screening questions afterwards. And Sarah, do you want to lead this discussion?
Yeah, thank you. Wonderful talks, all of you. Thank you very much. This is an interesting question for Marzia. In the plasma, the ratio of Guanedino acetate relative to controls is much higher in GAMP deficiency than you see in urine. Do you think there is reabsorption of Guanedino acetate by the kidney? And if so, is it by the creatine transporter?
That's a very good question. That could be. I honestly cannot answer that question. It could be a possibility, because we know that some of these analytes use the creatine transporter to go across across the membrane and across the organ.
Yes. perhaps I can add a little bit to that, because we looked into this a couple of years ago. So the tubular reabsorption of guanidino acetate in the proximal tubulus is accomplished by the D-basic amino acid transporter. So this D-basic amino acid transporter also reabsorbs arginine, lysine, cysteine, and ornithine. That's quite interesting, because it is one other mechanism, first of all, how high-dose ornithine treatment may work in reducing guanidino acetate, because high-dose ornithine would inhibit the tubular reabsorption of guanidino acetate and then lead to a higher excretion of guanidino acetate. And one of the treatment options that we have never tested, at least not for GANT, is high-dose lysine. That has been done for another condition, and this is hyperornithinemia. So I don't want to make kind of confuse you with many amino acids, but what is known is if you treat, and it seems to be safe, with high amounts of lysine, you get a higher excretion of the other D-basic amino acids, and you would also get a higher excretion or removal of guanidino acetate. So in theory, this is another treatment approach for GANT deficiency. I would be very curious to know how much contribution the creatine transporter has in all of that, because it is known that the transporter also transports guanidino acetate.
May I ask, what is the hesitation of suggesting that to a patient to try the high-dose lysine?
It's not a treatment that is approved, so you would have to do this on a compassionate basis. And yeah, I mean, I could also blame myself. I've never tried this in anyone.
Okay, so the next question, Marzia, was all your data that you showed from the ARUP serum urine testing, or was it a compilation from other labs? And would the reference ranges work in other labs?
So yes, the data that I've shown were all from our lab. These were pulled from our database. The reference ranges, whether the reference ranges work would be the same for other laboratories. I don't see, when I compare my reference ranges with other laboratories, there is very little difference. Mm-hmm. When even at the level of the newborn screening, we looked at values again with different methods and different laboratories, and the values are pretty consistent. So I think that again each laboratory should establish or confirm the reference ranges that they use, but I don't expect to see a big difference between laboratories.
Okay. A question from Sylvia about adding, would you consider adding Arginase deficiency to the guanidino acetate-based newborn screening? I think maybe she means by the second tier testing, and whether or not any baby with Arginase has been picked up by guanidino acetate.
So Arginase deficiency is already part of the screening panel. And so again, when I showed you the data that there is a correlation between arginine and guanidino acetate, clearly we had excluded arginase deficiency in those children, as well as GANT deficiency. I believe, I'm not sure 100% that there was a baby who has been picked up because of elevated guanidino acetate with arginase deficiency, but I am not I'm not 100% sure. I believe that this, I was informed of this, but I'm not 100% sure. But clearly, again, it would be a good second marker for Arginase deficiency.
One for both you and Heidi. What do you think about metabolite testing versus DNA testing for picking up all these disorders?
Do you want me to go first, Heidi?
Sure.
Well, you know, Sarah, being a biochemical geneticist, I think that metabolite testing, I strongly believe in metabolite testing, but I think, I believe also that now, more than ever, we need to have an integrated approach, and having metabolite testing and DNA testing and putting the data together is going to be that's what determines the power of your diagnostic approach. Typically, metabolite testing is available, and the results are available fairly quickly. So that's why, again, a combined approach might be the best.
Yeah, my parent answer to that would be that the metabolite testing is testing what is this body doing, and then genetic testing, you're looking for something very specific. You're looking for mutations. And I know of a family who did get a GAMP diagnosis, and they could only find one mutation because the metabolites screamed, "This is GAMP."
Kind of related to that, why, if GAMP was proved to be go to full review, why would you not include Agat and Creatine transporter?
Well, one of the criteria is that you have a proven test for the disorder. So it would be lovely if we could prove that. So there's two things on the RUS. There are primary conditions and there are secondary conditions. And there are secondary conditions that you're finding a disorder because you are looking at certain metabolites for a primary condition. And it's just a secondary finding, but they recognize that you can identify this disorder while you're looking for the primary disorder. So they include it on the list. So it would be great if we could have Agat and Ctd listed as secondary findings, as secondary disorders. But we need proof that the analytes that we are getting approved, the guac and the creatine, that those can be also used for and relied upon to indicate if a child has Agat or Ctd. And that's why I mentioned with Agat, that low level that we would think would indicate that it just kind of overlaps too much with the general population right now to make it realistic to screen for, because you have so many kids flagging in that range.
Yeah, perhaps along this line, there's another question to you, Heidi. Have you looked at the MPS, or the mucopolysaccharidosis community strategy for newborn screening? They are interested in having all mucopolysaccharidoses supported versus one by one. Might be interesting to connect with them with an exclamation mark. I would rather put a question mark on that, but what do you say?
I think that lines up with my previous comment. If they have done the work and each of the MPS have a proven methodology for screening, then that is a realistic approach to try to press for all of them at once. But where we don't, we only can really go to the rest and say, you can screen for GAMPs. We really can't say the others. So I'd love it if we could.
Yeah, I may take the privilege to make a comment here as well. So I would like to put out a word of caution to the families, to the ambassadors. One should always be very mindful of what the purpose of newborn screening is. And one also needs to keep in mind what the harms of a not properly done newborn screening is. So as you as parents and we as the physicians, we are biased towards diagnosing. We want to have the diagnosis, as soon as possible. That is good. But one also has to keep in mind that newborn screening can, identifying abnormal tests in neonate can have negative consequences. And so this is why the criteria to have a condition added to newborn screening are relatively strict, and they should remain strict. And one of the criteria is, for example, it is treatable. So if you keep this in mind, I would not advocate for CTD screening at the current moment. Research, yes, absolutely. If you find a newborn screening laboratory that want to do research, absolutely. But don't advocate for adding it to a statewide newborn screening right now. So that's the first thing. And the second thing is, of course, it needs to be a test, and Heidi said that, and Marzia mentioned it, that is not only very sensitive, it also has to be specific. That means if you go for low values, like for Agat, the specificity of such a test will be very bad. If you can do second-tier testing with gene or so, I mean, you can overcome all of that, but it also has to keep this in mind. And what MPS does is, I would definitely strongly oppose against basically saying, let's get everything on the screening panel. This is not helping at all. Good. Okay, so now this was my statement.
Okay. I don't know how much time we have. There are a couple more questions. One of them, Marzia, this one's for you. And I was trying to think of an answer from our own lab, but how often, when you see a value of creatine to creatinine in the urine of greater than 2000, is it going to be a false positive?
I need to go back and see how many. I don't think there are many values above 2000. Again,
yeah, we've seen a few false positives of that. Usually, rule of thumb that I use, if it's above 3000, you're more likely dealing with a creatine transporter, but it's probably about 50-50 if it's between, say, 1500 and 3000. That's just a very loose rule of thumb that I have. And then
yeah, it depends also if when you're looking at that, you have also available other tests. If you know that, for example, or if you have some clinical history. But yeah, I agree with you. The higher is the ratio, the more the better are your chances to be a true transporter deficiency. Mm-hmm.
And we have a parent, parents in the chat asking about turnaround times for their testing, and I think that might be, we could perhaps address that offline.
Yes, please. So thanks for mentioning the time, Sarah. And this is such a wonderful conversation that it was breaking my heart to like jump in. But thanks, Marzia, and thanks, Andreas and Sarah and Heidi and Sophia. I think newborn screening was a big achievement for the entire community, GAM newborn screening for this year, and we're very hopeful to see it move forward.